Welcome everyone, I'm Claudia Kesch, a urologist from the University Hospital in Essen. We are here at EAU25 TV and I'm here with Associate Professor Bryant, one of the academic directors of Surgical Intervention Trials Unit at Oxford University and the lead investigator for the TRANSLATE trial. Welcome. And actually the TRANSLATE trial is what we are going to talk about today. Can you let us know a little bit what it is all about?
Yeah, thank you, Claudia, and thank you for the opportunity to present on EAUTV. So for many years, as you will know, we have been performing prostate biopsy via the transrectal route, following a pre-biopsy MRI. But in the last few years, there's been great interest to potentially change the modality of biopsy, and rather than biopsy through the rectum, instead to biopsy through the perineum, through the skin between the scrotum and the back passage. And the big driver for this has been the possibility to reduce the risk of infection from the biopsy process. However, men don't have a biopsy to avoid an infection. They have a biopsy to hopefully exclude or to identify clinically significant prostate cancer that might need treatment. So we set up the TRANSLATE trial in the United Kingdom, my co-lead Alistair Lamb and myself, to rigorously evaluate transperineal biopsy in the clinic under local anaesthetic against transrectal biopsy. Okay. Now, in the time that we were doing this study, 3 other trials published in this space. 2 trials from the US, one by Badamian and another by Jim Hu, and they were looking at infection as a primary outcome. And then a 3rd trial from France by Ploussard, which was looking at detection of significant disease as a primary outcome. And those 3 trials, excellent trials, they showed no statistically significant difference. However, in TRANSLATE, we powered the study to identify an uplift in detection of grade group 2 and higher prostate cancer if it exists for LATP versus TRUS. And we conducted this trial throughout the UK, 10 centres. Okay. And we were pleased to be able to show the data today with simultaneous publication in Lancet Oncology.
Perfect, wonderful. Congratulations on this achievement. And now we definitely want to hear something about the results.
Sure. So in the in the analysis of the primary outcomes, we did see a uplift in detection of grade group 2 and higher prostate cancer of 5.7% in the LATP, men who were randomized to receive LATP versus TRUS. And this reached statistical significance. And we observed that in the intention to treat population. We also observed statistical significance in the per protocol population. Now, this fell slightly short of the 10% that we hypothesized, but actually we found that the rate of detection of grade group 2 disease was higher, even in the TRUS arm, the transrectal biopsy, as compared to what we hypothesized. But when we did a robust statistical analysis, we see statistically significant elevation in detection in our primary outcome, which we were happy to share today.
Oh wow, and this is really the first study showing that there
Correct.
Is a significant difference.
Yes.
So this was the primary endpoint. Can you tell us a little bit about the secondary and other endpoints?
Yeah, sure. So we looked at a number of different really important secondary outcomes. So on the subject of infection, we find that men who were randomized to receive local anesthetic transperineal biopsy, they do indeed experience fewer infection-related events than the transrectal biopsy group. This didn't reach statistical significance, but that's largely due to the low numbers of infections that were happening in each arm, but there were fewer in the LATP arm than the transrectal arm. That's important. The other important thing to point out is that almost 90% of the men who had the transperineal biopsy had those biopsies safely without antibiotics. And this is really important for antibiotic stewardship, given that there's rising rates of antibiotic resistance and so on. So that was an important conclusion. We also looked at other patient-reported experiences from the biopsy, so tolerability, for example. what we observed was that men, in the immediate few moments after the biopsy had been completed, they reported greater levels of discomfort and pain and embarrassment for the transperineal biopsy compared to the transrectal. But when we also evaluated at other time points following biopsy, for example, at 7 days post-biopsy, those men who'd had a transrectal biopsy were more likely to report ongoing symptoms of the biopsy.
But wouldn't you say that this is a little bit paradox? So why do you think that is?
Yeah, so I think there's definitely more work to do around the sort of biopsy experience for men. But one possibility is that the position that the man adopts to have the biopsy is different for the two types of biopsy. So when men have transperineal biopsies, they lie on their backs, they have their legs up in support stirrups, they're facing the person doing the biopsy, the procedure takes longer. So maybe those things factor into the embarrassment that they feel, as opposed to transrectal when they're in the left lateral position, which is quicker and facing away from the biopsy. We looked at sexual and urinary function related events. There was no difference, which was interesting to see. Post-biopsy retention of urine, needing a catheter, was no different between the two biopsies. We also looked at an alternative definition of clinically significant disease, because this is evolving.
Yeah.
And when we looked at grade group 3 and above prostate cancer, we saw no difference. And then the final thing to mention is that we have started to now conduct the full rigorous health economics evaluation. And actually, when we accept the caveats that this is based on NHS costings in our UK healthcare system, and the fact that it's 4 months of follow-up, the probability of transperineal biopsy being cost effective is very low. It's less than 1%. And we think that this is related to a combination of the fact it takes longer to do the biopsy, and there's that increased discomfort immediately post-procedure. So we've not published the health economics work yet. That's a publication that's in preparation at the moment. But I was able to share some of that data today.
Okay. And how do these results affect your own practice?
Yeah.
Will you still perform trus biopsies now, or are you going to switch completely to transperineal?
Well, in Oxford, which is the hospital that I work at, we've still been doing both types of biopsy in certain scenarios. I think the key thing that we were excited to do today with the audience is provide robust level 1 evidence to the field, adding to the data we already have from the 3 other trials that I mentioned. And really this now provides guidelines committees and others an opportunity to look at the trade-offs, because there are trade-offs between these two types of biopsy. And then the guidelines committees, urologists, patients, they can all then analyze the data and decide which type of biopsy either to adopt or to keep, or maybe keep both, but in different scenarios. So it's been a great honor for me to lead the trial with my co-lead, Alistair Lamb, as I mentioned. We're really grateful to the 10 centres in the UK that recruited patients from 3 of the home countries of the United Kingdom, England, Scotland and Wales. We're really grateful to our funder, the NIHR HTA programme. And most importantly, we're grateful to the 1,126 participants who were recruited to the study.
Yeah, that's important. Thank you so much, and congratulations for running this great trial.
My pleasure, and thank you for allowing me to speak.
Thanks.
Okay.